adults with diabetes. And as Jan mentioned, I am currently a CDC Public Health Advisor assigned to the Indian Health Service Immunization Program. I'm currently serving as the Interim Immunization Program Manager, and I've been in that capacity for the past 2 years, but I have been with IHS for the last 4 years. So our program is actually very, very unique that we have a partnership between CDC and IHS, and so we are a mix of CDC and IHS staff working on behalf of immunizations within American Indian and Alaska Native communities. And as Jan mentioned earlier in my introduction, I have my MPH in epidemiology, and my background has been working with tribal communities in chronic disease, tobacco prevention, and immunizations over the last 14 years. And I've been working specifically in immunizations over the last 10 years. And I'm currently working on my doctorate in public health leadership at the moment. And so I'm looking forward to getting into where we stand today with immunizations for adults with diabetes. So first, my disclaimer that I do not that my opinions are not reflective of the Indian Health Service or the Centers for Disease Control and Prevention. And here is a brief overview of some of the topics that we are going to discuss today. And we have a lot to go over, so I'm going to just get right into it. So why do we need immunizations for people with diabetes? And I know many of you have background working specifically in diabetes, so I don't need to tell you about diabetes, but for anyone who maybe is new to diabetes and just wondering to get more information, just real quickly, as you know that people with diabetes have a harder time fighting off infection due to having weaker immune systems and are at more risk or increased risk for serious complications to illnesses compared to those without diabetes. Specifically, we know that certain illnesses can influence high levels of glucose rates. As we can see here, influenza in particular can raise blood glucose levels to really high levels. We know that hepatitis B among people with diabetes is higher, mainly due to sharing of blood products back and forth or sharing glucose monitors. And there's also increased risk of illness or death from pneumonia. Our best strategy is immunizations to protect against these vaccine-preventable diseases, and vaccines are one of the safest ways for people with diabetes to protect their health and stay protected. So this slide is a picture of the current adult recommendations for immunizations for all adults ages 19 and above. And I know the slide can be kind of confusing, so I'm gonna practice using my pointer today. But first, just to start with, to orient everyone, here on the left-hand side are all of the recommended vaccines for adults. And then across the top, it's broken down by age groups, as you can see here, 19 to 26, 27 to 49, 50 to 64, and 65 and older. They have tried to do a better job of color-coding this chart to make it easier for clinicians and for parents and other providers to be able to understand the recommendations. So I'll go through them pretty quickly here, but those that are in yellow, these are the routine recommended vaccines. And as you can see here, these are depicted here in yellow. For the vaccine recommendations that are in blue, this is now called shared clinical decision-making. This used to be called Category B recommendations, but they have changed the term to shared clinical decision-making. And what that means is that it is a conversation between the provider to determine if they feel, based off of their health and their needs, if this is appropriate vaccine for them if they are within that age group. And then the colors that are blue or purple, are for those who have specific medical conditions that may require vaccination of other vaccines outside of the routine recommended vaccines for adults. So this slide gives each of those vaccines in more detail. And as I just mentioned, so we have TD and Tdap are required for adults. TD, 1 booster every 10 years, and Tdap, 1 dose. Ages 19 above, at least 1 dose as an adult. For human papillomavirus or HPV vaccine, the recommendations were recently changed in 2019 to include all females and males 19 through 26 years of age to receive HPV vaccine. And now there is the shared clinical decision-making, and I added patient decision-making because it's really a conversation between the clinician and the patient, for those between the ages of 27 to 45 to discuss if HPV vaccine is appropriate for them. We also have a zoster vaccine for patients aged 50 years and older, as well as influenza annually. and meningococcal B vaccine for those 19 to 23, again, depending on shared clinical and patient decision-making. And then, as Karen mentioned, there are 2 pneumococcal vaccines, and within the recent year, the recommendation for pneumo has changed, and I know I always get a lot of questions about pneumo, so hopefully we can spend a little bit of time going through this because I know it can be confusing. But here's just some additional information. I'll go into more detail on later slides regarding the new recommendation specifically for PCV13. But as you know, pneumococcal, there are certain risks among American Indian Alaska Native populations, and pneumococcal vaccine is one of those important vaccines to receive. So which vaccines do we need for those diabetes? There are 5 specific vaccines that are needed for patients who have diabetes: pneumococcal, influenza, hepatitis B, zoster, and Tdap. And on this slide, I've provided, again, similar to the routine vaccine slide, this is specific for adults who have certain medical conditions. And I've highlighted here the diabetes column, and then I've highlighted in green, and in red I've highlighted the vaccines in red, those 5 that I just mentioned that routinely for patients with diabetes should receive. So why is pneumo and influenza an area that we really want to highlight? As many of you probably are aware, American Indian Alaska Native people are twice as likely to die from pneumonia and influenza than non-Hispanic whites, and it's among the top 10 leading causes of death among American Indian Alaska Native populations. They are significantly disproportionately affected by influenza and pneumonia compared to others. And influenza vaccination still remains to be the best strategy for reducing influenza-related illness. And in addition, during 2009 H1N1 influenza pandemic, American Indian and Alaska Native people were 4 times more likely to die from influenza-related complications than other racial groups. And one of those reasons had to do with chronic medical conditions, which included diabetes. And I did not include coronavirus on this slide, and I apologize. In hindsight, I probably should have, but even more so now as we go into flu season, we are really encouraging everyone to please get vaccinated for influenza because, as you know, coronavirus is still currently circulating, and as a way to reduce other respiratory illnesses and burden on the healthcare system, making sure your patients are vaccinated with influenza this season will help with that. And we also know that COVID-19 complications are increased among American Indian and Alaska Native populations, and especially those who have underlying illnesses like diabetes. So there are 2 vaccines, as I mentioned. Sorry. There are 2 vaccines, as I mentioned, that help protect against pneumococcal disease. There's pneumococcal conjugate vaccine, or PCV13. Then there's the pneumococcal polysaccharide vaccine, or PPSV23. And diabetes is a risk factor for invasive pneumococcal disease, which is why it's recommended for adults with diabetes to receive 1 dose of PPSV23 before the age of 65. So between ages 19 through 64, they should receive 1 dose. And then after they turn 65, they should get a 2nd dose. And here on the slides is just an infographic to help to break that down because the recommendations can be really confusing. Here, I'm just another graphic to help to understand the differences between the dosing schedule. And I'll go into more detail about PCV13. But specifically for patients with diabetes who have no other health conditions, they do need to get, here as you can see, let me use my pointer so I can show you where I'm talking here. They do need at least 1 dose of PPSV23 at 19 through 64 years of age, as you can see indicated here. Now, the main thing to point out is that they need to have at least 5 years spaced out between their 2nd dose, which they should be receiving after they turn age 65. However, if you have a patient who's diagnosed with diabetes in their late 60s and they receive a dose of PPSV23, just remember to keep in mind that they have to wait 5 years for that 2nd dose after they turn 65. Now, if your patients also need PCV13, which in the past, PCV13 was recommended for certain conditions, and the recommendations have changed. However, if they do need PCV13, this graphic here will break down the spacing that is required. So there is at least 1 year of spacing that needs to happen between PPSV23 and PCV13. And then another year spaced out between for them to receive that second dose of PPSV23 for a total of 5 years in between that first dose of PPSV23 and that second dose. There we go. Sorry about that. But let me break that down a little bit more clear. So again, PCV13 vaccination is no longer routinely recommended for adults 65 years and older. It's now based off of shared clinical decision making and for routine for adults over the age 65 that do not have immunocompromising conditions, cerebrospinal fluid leaks, or cochlear implants. Again, previously up until last year, this vaccine was being given to both adults 65 and older, but now PCV13 has not really shown that the need for that protection is needed, given that we have been given the pneumococcal conjugate vaccine to pediatric patients. There's actually more protection in the community by giving it to children than by giving it to the adult population 65 and older. And diabetes is not considered an immunocompromising condition for this vaccine, which is why it's not recommended for patients with diabetes to receive PCV13. Again, here this graphic breaks down the, if you do have someone who has diabetes but also other immunocompromising conditions, this slide breaks down into a nice graphic, the spacing and the doses. But given for time, I'm not going to go into that, but you can reference this back if you want to understand the spacing components. Influenza vaccine, as I mentioned, we are now in the beginning of influenza season, and as you know, it's a very contagious respiratory illness caused by influenza viruses circulating, different strains that are circulating, and people with diabetes are at even more increased risk of complications, hospitalizations, or illness due to flu. And now is a great time to encourage all your patients to get vaccinated as we approach flu season, particularly given coronavirus as well being circulating in the community. Our current recommendation still stands the same, and annual influenza vaccination is recommended for all persons aged 6 months and older who do not have contraindication. And on this slide, I've broken it down by, we have two main types of influenza vaccines, and products have changed quite a bit over the last few years. So we have some vaccines that are still egg-based, and as you can see here, we have, oh, sorry, let me get my pointer to work here. 4 products, oh, my pointer's not working. I can't get the pointer to work, but we have 4 products that are one specifically for 6 months and older. That's 4 that are inactivated here, represented by the IIV4, and then 3 that are high-dose vaccines for those 65 and older. And then we also have a live attenuated vaccine, FluMist, that is also egg-based. So all 4 of these vaccines are egg-based. 3 are specifically for adults 65 and older, 1 for 6 months and older, and the FluMist is for those that are healthy 2 to 49-year-olds. And what does that mean? So that means this particular vaccine is really not indicated for patients with diabetes, and I've put here in the right-hand side and highlighted the diabetes section that is not recommended for patients with diabetes, so it's a contraindication. So I wouldn't recommend FluMist to any diabetic patients, but any of these other 4 vaccines here at the top are recommended for patients with diabetes. And some of the requirements for egg allergy has changed recently over the years as well. Previously, those with egg allergy may not have received flu vaccine, but ACIP now recommends that a person with egg allergy of any severity receive influenza vaccine. And I have a slide that breaks that down into more detail as well. And then we have 2 other non-egg-based vaccines. One is a cell culture-based vaccine, and the other is a recombinant vaccine. All of the current influenza vaccines are quadrivalent this year, which means that they include 4 strains of influenza to better protect us. The cell-based vaccine is licensed for ages 4 years and older, and the recombinant vaccine is for adults licensed 18 years and older. So the newest recommendations for persons with egg allergy, currently if you've experienced any hives after exposure to eggs, it's now recommended that you receive any licensed age-appropriate influenza vaccine. So this can be inactivated, recombinant, or live attenuated or FluMist vaccine. Those who've reported any symptoms other than hives to eggs, they recommend that they assess, what has occurred and determine if an influenza vaccine is appropriate. However, if they've had very severe allergic reaction to any influenza vaccine, it's not recommended that they receive influenza vaccine. That would be a contraindication. But the main point of this slide is that no longer is just an allergy to eggs going to be a reason to not offer flu vaccine to a patient. We'll now shift over and talk a little bit about hepatitis B and diabetes. And as you know, hepatitis B causes acute and chronic infection of the liver, and it is found to be 2 times higher among diabetics compared to those without diabetes. And this has been mainly due to sharing of blood glucose meters or other diabetes-related equipment that it requires any type of blood that's coming through or insertion in the body. And this has been documented through numerous hepatitis B outbreaks among people living in assisted living or long-term care facilities who had diabetes. And as a result, now this recommendation is here, hepatitis B recommendation for patients with diabetes. So for those who have diabetes, it's recommended that they be vaccinated with hepatitis B vaccination if they have not received this vaccine as soon after they've been diagnosed with diabetes. And it should be given to adults diagnosed with diabetes in the past as well. And this hepatitis B vaccination can occur at the discretion of the healthcare provider for those who are over 60 years and older. There currently are, since probably the last time you've heard, is a new product that's on the market. We now have a 2-dose and 3-dose series of vaccines available. And the 2-dose vaccine series here, Hepatitis is been pretty well received in the community. But you also still have the option for the 3-dose series here in Genrix B and Recomvax HB to provide. But the main thing is to note that if you have patients who are struggling to go back to get that 3rd dose, there is now another option available to be vaccinated. So they are trying to find newer products to make the time and the spacing a little bit shorter for patients to get into this facility to get their full coverage. There's also zoster vaccine that's on the market, and as you know, shingles is a rash that can appear anywhere on the body, causes blisters, can be really painful. And there currently are 2 shingle vaccines currently recommended. However, the first one that first came out on the market, zoster vaccine or Zostavax, has no longer been supplied in the U.S. as of July 1st of 2020. However, patients can still receive that vaccine until it expires of November 1st of 2020. This particular vaccine is recommended for those 60 years and older, and it's only 1 dose. And the second vaccine, which actually has a preferential recommendation by ACIP, is the recombinant zoster vaccine or Shingrix, and that's recommended for patients 50 years and older, and it's a 2-dose series spaced out 2 to 6 months apart. And the other vaccine that's recommended for patients with diabetes is Tdap. And as I mentioned earlier, CDC recommends that all adults over the age of 19 and older get at least 1 dose of Tdap vaccine in their lifetime, and then a booster dose every 10 years. One of the recent changes that has occurred is that it doesn't have to be a TD that they receive now for the boosters. It can be a Tdap. So every 10 years they should get a TD or a Tdap, or at least 1 Tdap if they haven't gotten it over the age of 19. So while we're talking a lot about adults, we do also know that there are some adolescents, young adults and adolescents who may come in and present for care for diabetes and be diagnosed with diabetes. And I wanted to also stress the importance of adolescents receiving the same vaccines for persons with diabetes, PPSD23 and hepatitis B, as well as the recommended adolescent vaccines for their age group. And let's see if I can get my pointer to work. No, still not working. And you know, I highly suggest using reminder recall functions within your EHR if you have IHS RPMS, or utilizing the state IAS to determine which vaccines are needed for your patients. But here on the right-hand side, I have broken down in this table the vaccines that are recommended currently for adolescents. We have 2 meningococcal vaccines. The meningococcal conjugate, or MenACWY, is recommended at the ages of 11 to 12. It's 1 dose with a booster dose at 16 years old. Then we have the second vaccine, which is meningococcal serogroup B, meningococcal or MenB vaccine. which is recommended for 16 to 18 years of age, and there are 2 doses of that vaccine. For the HPV vaccine, we have 2 different dosing requirements based off of the age in which they initiate this vaccine. So if they start this vaccine at 11 to 12 years of age or before 15, they would receive 2 doses 6 to 12 months apart. If they start this vaccine after they turn 15, then they would need to get the full 3-dose series. So that has been a recent change in the last few years. They are also need 1 dose of Tdap, again recommended between 11 to 12 years, and influenza vaccine every year. So immunization coverage. So how do we compare? As Karen demonstrated earlier and shared the results from the diabetes audit, I wanted to share with you some of the numbers that we have available from the U.S. population data comparing to our 2019 IHS RPMS adult reports. And I would just like to note that, again, these are different data sources, so they may not be directly comparable, but just to demonstrate kind of where we are with our coverage. And as you can see here, starting with our TD Tdap coverage, U.S. population in the dark blue hovering in that low 60s, and our IHS adult report in the lighter blue a little bit above 70%. So we're doing okay with Tdap. Our influenza numbers, as you can see, are much lower. We are in the mid-30s every year for influenza. So I hope this year we can improve that a little bit. For our zoster coverage right now, we are currently tracking those who've received zoster vaccine 60 years and older. However, for future reports, we will hopefully be tracking those who've gotten zoster at 50 years and older for comparison. But as you can see here, compared to the U.S. population, our population has done well so far with receiving, at least over 50% have received their vaccine for the year of 2019. And for our pneumococcal coverage, this slide is only showing those who've received the PTSV 23, not the PCV13, at age 65 years and older. But as you can see, we, for 2019, almost made it to 80% coverage, which is pretty high compared to the U.S. population, and I think is pretty comparable to the data that Karen showed earlier. For our adolescents, this is just over, since fiscal year 2012, kind of over the lifetime of our coverage and where we've seen our Tdap, meningococcal coverage, and our HPV coverage among 13 to 17-year-olds has maintained relatively stable over the years, and pretty much in the high 80s, low 90s. So we've been doing really well with our adolescent vaccination coverage as well. So what are some of the challenges for vaccinating adults? You know, some of the issues that we have heard on the immunization program is access, sometimes having to do with transportation, being able to get to the clinic, or patients not coming into the clinic, also being able to reach patients to remind them of their appointments to come to the clinic. So that can be a challenge to ensure that patients come back, especially for vaccines that have more than 1 dose. There's also been refusals or some hesitancy among receiving vaccines in different communities. And then we also know that adult vaccines, as new ones come out, there's increasing costs and reimbursement, and that can also cause challenges in getting patients, adult patients vaccinated. And just for everyone's awareness, all ACIP recommended vaccines are included on the IHS core formulary and are recommended for use. And at the provider level, we know that sometimes there's not always a strong recommendation for vaccines, which results in missed opportunities, and also not assessing what is the current vaccination status for that patient. You know, they may come in to the ER for a hurt ankle, and that could have been an opportunity to assess their vaccine needs and provide a vaccine to them at that time. As I mentioned already, there's also the vaccine hesitancy and also just lack of awareness about what vaccines they may need and why they are beneficial to their health. So hopefully keeping that in mind when talking with your patients, diabetic patients, on the importance of receiving immunizations for their health, I think will help to encourage use of immunizations. So thinking of strategies and best practices, we suggest you follow some of the standards that have been recommended for adult immunizations, which is assess, recommend, vaccinate, and document. So again, to assess, really utilize your provider reminders in your EHR, whether that's if you have RPMS or if you have your own EHR within your facility, monitoring immunization coverage on a more frequent basis, weekly, bi-weekly, monthly. I know you all are extremely busy, and it can be really challenging to do that, but I think knowing where you stand with your data will help for you to know how best to identify who you need to reach out to. Again, making a really strong recommendation for vaccination and why I think will help to encourage people, and providing them with the education and information that they need will help as well. Vaccinate, again, standing orders or expanding access. Again, I know many of you all in this current season have had to change maybe how you provide, how clinics are providing vaccines within the immunization clinics. Some are doing drive-through clinics or drive-through clinics. So I know having to think outside of the box for that. And then again, documenting, utilizing your reminder recall strategies, whether that's through the state immunization registry or through your EHR. If you have RPMS, we have built-in reminder recall functionality there. And just documenting if any vaccines have been given at their locations, which will help as well as to reduce giving more vaccines than are needed to a patient. And just briefly, I wanted to touch on some of the RPMS EHR tools for those who do have RPMS. As I mentioned, we have our forecasting system or their clinical decision support, which within the RPMS EHR, which will identify, and we just actually implemented a new forecasting system called ICE in this past spring. And so it aligns up with all of the ACIP recommendations currently, and it takes into account the minimum intervals and ages and spacing requirements for the vaccine that's required for that patient based off of their age. And we also do have our high-risk module still in place, so particularly for patients with diabetes, the RPMS system will recommend pneumococcal conjugate, or I'm sorry, pneumococcal polysaccharide vaccine, and as well as hepatitis B vaccine for any patient with diabetes in the system. And so that's another opportunity to ensure that they're being vaccinated on time with the vaccines that they need for their age. And as I mentioned as well, we have the list and letter function within RPMS. It's only currently available in the roll and scroll environment, not in the EHR, but it can be used to generate specific lists for patients who are due for specific vaccines, or to assist with reminder recall efforts. And I did include the link here for more information on the RPMS immunization package resources. There are a few templates and recordings available to you if you would like more information. And we also, here's a list of the provider reminders that we currently have in the EHR. I'll just point out the PCV13 for adults. We are in discussions of updating this for shared clinical decision making, as some areas have felt that they would like to have a prompt in place. And then we're also in development of a reminder or some kind of a prompt in place for HPV for 27 to 45 years of age. But this just lets you know just a quick list of all the other reminders that we currently have available in RPMS resources. So the next few slides are just some resources that are available to you. On the IHS website, we do have our weekly surveillance reports for flu, where you can see kind of where we are with our not just our immunization flu coverage, but also with surveillance of flu within which area. And then we also have a healthcare personnel vaccination policy, a mandate required for federal facilities for flu by October 1st. And then the CDC also has some resources available as well. They also do weekly surveillance reports, provide their flu activity data, and then they have some educational materials that might be useful to use as well. And then partners outside of IHS and CDC include Immunization Action Coalition and the National Foundation for Infectious Diseases. They have a few materials that may be of use for you as well. I wanted to just include that here for you as a resource. And then a couple of years ago, the immunization program partnered with the Great Plains Tribal Epicenter to develop adult immunization resources and flu immunization resources that actually are available in a non-branded format. The ones that are pictured here are branded, but you can go to the link that I have posted here, and you can download these and use them however you may like and brand them to your facility. But the nice thing about these are there's a poster, there are flu vaccination cards. We also have 2 videos that are a conversation between here, this video is depicting a conversation with an elder who is also a community health representative for his community talking about adult immunizations, and that is available on YouTube. And then for the flu, we have a similar video for flu also available on YouTube, as well as posters, vaccine cards, and other materials that are available to your use. And again, here is the resource and the link for you if you choose to download those or to at least check them out and see if they're useful. And then I also wanted to provide just some of the resources that CDC has specifically for diabetes and adult vaccines here on the left-hand side. Here in the middle is a sheet on all the vaccines that are recommended for adults with information as to why they are needed. And here in, also from CDC is flu and why people with diabetes need flu. And then on the right-hand side is just a really fun infographic about living with diabetes and getting vaccinated and protecting yourself with those 5 immunizations that we discussed earlier. And here's a list of all of the resources that I've discussed today in my presentation, and I highly encourage you to also check out the Association of American Indian Physicians. They developed an influenza media toolkit and some PSA videos a couple years ago that I think also could be a useful resource during our flu season right now as well for your use. And here's my contact information if there are any questions or if you would like to reach out. I know this is a lot of information in a really quick time, and so I thank you all again for your time today, and I'm happy to take any questions. Thank you.
Thank you, Jillian, for just a great, informative, and timely presentation, and the benefit of lots of resources to go back and look at ways to communicate this with our patients. And everyone, if you want a copy of the presentation slides with all those resources listed, they're available for you in the downloads box. Jillian, we had a couple of questions. Do you mind taking those? I can read them for you, or if you want to read them and respond to them, that's fine too.
Sure, yes, thank you. I can, Jan, thank you. So the first question that I received is a patient received Zostavax, which is the zoster or shingles vaccine 5 years ago, but the EHR is asking for Shingrix now. Is it one or the other for zoster vaccines? So I'll give you a little background on that requirement. So when, so as I mentioned, this spring, this is related to RPMS, for those who are wondering. This spring we deployed a new clinical decision-making system called ICE, and ICE included an update to the recommendation for use for zoster vaccine. So previously our older clinical decision-making software required a spacing between those who got Zostavax to not get it for 5 years, to space that out. However, the recommendation from the ACIP is that if a patient received Zostavax and they should receive Shingrix at least 8 weeks apart from that dose of receiving Zostavax. So the reason you're seeing this now is because that is part of the requirement. When we switched to the new clinical decision-making system, it forecasted based off of the current Advisory Committee and Immunization Practices recommendation that anybody who's received a Zostavax previously should be vaccinated with a Shingrix vaccine at least 8 weeks apart. So at the time, so now that's why you're seeing that now. So it's just not one or the other. However, they do state that, if a patient has a preference or if there is concern about the other vaccine, they don't want to force the vaccine on anyone, but that is why you're seeing that there. So if your patient received the Zostavax 5 years ago, they would be due for Shingrix, for 2 doses of Shingrix vaccine now. They should not get another dose of Zostavax. So I hope that, I know that was a really long response, but it's kind of complicated, so I wanted to provide a little bit of background. So hopefully that answered your question, and if not, please post it in the chat. And the second question I have is there a template for standing orders? And I don't have a template readily available for standing orders, but I could request one. There are some, everybody has them specific to their facility, but I can request one and share that out. And I know that there are, I forget which website there is, but I think it might be somewhere on the CDC website, like a standard general template for standing orders, but I can definitely follow back up with that and share that with Jan.
Can I just put one more question up there for you, Jillian?
Okay, sure. So the next question is, if a person with diabetes had a pneumovax at age 65 years or older, does he or she need another dose at some point in the future? So I think the question would be, is this their first dose or their second dose? And I'm going to go back to the slides where I have the graphic, because pneumo can be a little confusing. So if the person who, so I'm going to repeat the question again. So this is about a person with diabetes who had pneumovax at age 65. So the recommendation would be that they should get a second dose at least 5 years after the last dose. So if they got their first dose at age 65 and they were also diagnosed with diabetes at age 65, then in 5 years from now, they should get another dose. If they were diagnosed with diabetes at age 40 and they didn't get their first dose of pneumovax until 65, they still would need a second dose 5 years from now. If they got that first dose, though, before they were age 65, they only need that second dose after age 65. So I think it just depends on the timing of when they received the first dose. And just make sure that there's a space of 5 years in between the first and the second dose. But thank you for that question, because pneumo can be very confusing. And I think it was more confusing when we had PCV13 in there.